Dear friends, very good morning to all of you from CMC and from the COVID Command Center Training Desk. As we continue to grapple with this pandemic and each day as we face various challenges and we see the numbers soaring, especially the issues around oxygen demand, oxygen supply, and how do we optimize the respiratory therapy for our patients. So today is the second of our series during the second wave. And before we start, as we seek our collective wisdom, we bow down our heads in a brief prayer. Heavenly Father, we come to your presence this morning. Thank you for this new morning in our lives. We are so fortunate to see this morning in our lives, Lord, when many of our friends, our family members are not in this world. Protect all the healthcare workers, protect all the people in the community. Lord, we pray that you be with the people who have lost their near and dear ones. Strengthen them, O Lord. As we listen to this topic today, help us to gain insights into how to optimize the respiratory care and ICU care for these patients. Be with the speakers, let your presence be there. In Christ's name we pray. Amen. Dear friends, we welcome all our members from CMC community, and also we have many of our doctors who are working out in the remote areas of our country in various mission hospitals. And we also have some people who may be outside the network, so a special welcome to all of you. For today's topic, we have our moderator is Dr. Balamugesh, who is a professor and head of respiratory medicine. And I may like to invite Dr. Balamugesh to introduce the speakers, the topic for today, and moderate the session. Over to Dr. Bala.
Good morning. I'm grateful for Dr. Thomas Ram, the CCC training desk, Dr. Anand Sakaria, to make this session possible. And this is very important, especially when we are facing a national health emergency and oxygen crisis. As you all know, in majority of patients, 70% of symptomatic COVID patients, the disease is mild. They may not require hospitalization unless they have risk factors, and it can be managed on home isolation. Rest of them, they may have moderate disease. According to Union Health Minister Dr. Harshvardhan, in his statement 2 days back, 4% of COVID positive patients require oxygen, and around 2% require admission in an ICU, and around 0.5 to 0.5% require ventilator. I don't know the source of his calculation, so this is a rough statistics according to the government of India. 4% of COVID patients require oxygen, 2% requires ICU care, and 0.5 invasive ventilation. And the topic for today is respiratory care in a COVID positive patient, how to manage them by non-invasive ventilation and invasive ventilation. We have two eminent speakers. They are pioneers in the field, I would say so, because they have hands-on experience of managing such patients. They have innovated strategies, methods, and plans, and developed their field to provide them care to these patients. The first speaker is Dr. Barney Isaac, professor in Department of Pulmonary Medicine, Christian Medical College, Vellore, and followed by Dr. Binila Chacko. She is professor in Medical Intensive Care Unit, CMC Vellore, and she is also the Deputy Director in charge of quality in CMC Vellore. Over to Dr. Barney Isaac. And during the session, please free to type in your questions, comments, suggestions in the chat box, either in the Zoom platform or in the YouTube platform. And we will be addressing that at the end of the session. Thank you.
Good morning, everyone. Thanks, Dr. Balamugesh, for the words of introduction. I thank the CCC training group, Dr. Anand Zakaria, Dr. Thomas Ram and team for giving me this opportunity. So the task that has been given to me today is to look at the when and how to do NIV in COVID-19. This will be based on protocols that we've put in place, evidence that we've gathered, and the learning curve that we've had during the first wave of the pandemic as we get ready to enter into the second wave. So I'll be briefly touching on the relationship between NIV and COVID, the evidence that is probably sparsely available so far, the when to and the when not to, and the how to and how not to. Looking at the relationship, non-invasive ventilation is providing ventilation without the access through an endotracheal tube or a tracheostomy tube. So it is through interfaces between the machine and the face. So it conventionally involves pressure support. Unless you give pressure support, those are very stringent in the way the terminology is used, would call only the bilevel pressure mode as NIV. But the liberalists would agree that even CPAP, which is continuous positive airway pressure, can be considered under NIV. And in the context of COVID, it has become reasonably synonymous to put both CPAP and BPAP under the same basket of NIV. Now, COVID ARDS particularly had initially was thought of to have some differences from the other ARDS which we have faced in the past, other causes of ARDS. This is still to be contended. But however, it appears that non-invasive ventilation seems to have a higher role in COVID ARDS as compared to other ARDS. If you look at the evidence that has evolved so far in the last 1 year, there is one randomized control trial, not more than that at all. This was published only last month in JAMA, where they have compared non-invasive ventilation in high-flow nasal cannula in patients who had COVID ARDS with a PF ratio of less than 200. And their primary outcome is number of days the patient was requiring respiratory support, and they did not find any difference in the primary outcome. Only 110 patients were studied. So we have only one study comparing NIV and HFNC and with a negative outcome. However, there are about 40 observational studies, all of which report significant impact of NIV on patient outcomes. But the unfortunate thing is that we don't have a control group. Then there are about 99 reviews, perspectives, and case reports, again, stressing on the fact that NIV probably has a role in COVID ARDS. I would like to just allude to the experience that we had in the ICU, which was the Respiratory Intermediate Care Unit that we initiated in July last year in the middle of the pandemic. So for over nearly 4 months, we had about 318 referrals and 272 admissions. Out of this, more than 2/3 were step up from the ward who required NIV. 1/3 of them were stepped down from the ICU, which we managed. A small proportion were directly admitted from the emergency department for NIV care. And the next part of the flow chart shows us that about 80% of them were transferred back to the ward. 7% of them were stepped up to the medical ICU because they worsened, and around 12% of them died. Now, this proportion had, if we take away the proportion that was stepped down from ICU and were primarily initiated on NIV as a step-up mechanism, then we would say the success was about 85% and 15% mortality. But what is important to note is that among the patients who died, only one patient was for full escalation and succumbed to the disease while he was on NIV. The others were 10 who were de-escalation from the critical care, and 22 in whom NIV was the ceiling of care, which means if they did deteriorate on NIV, that was the ceiling of care that was decided along with the relatives and the treating team. When to do NIV is also an important question, along with which comes when not to do, because if we start too early, we will be wasting our resources, and probably these patients would have benefited anyway. If we start too late, then the success rates would not be good, and many of them would probably go on to require ventilation. Having said that, this is not entirely clear, the clear timeline or patient time front line where it needs to be initiated. One of the things that we understood during this process was the body's response to hypoxia. So our initial algorithm of indications had a lot of focus on the respiratory rate, where if the patients were tachypneic, then we would initiate them on NIV early. But soon we began to understand that there are multiple factors of tachypnea in these patients, and tachypnea actually is not, although it is the response of hypoxia could have tachypnea, the work of breathing that is increased is a more precise indicator of worsening respiratory distress or response to hypoxia or response to initiating treatment. So that is because when the patient is tachypneic, there is rapid shallow breathing. So the minute ventilation, which is a product of the tidal volume and the respiratory rate, remains constant. So actually the patient takes multiple breaths, and there is increased distribution between the anatomic dead space, which increases, and the alveolar ventilation, which actually decreases. So actually it doesn't help in hypoxemia. In fact, what helps is hyperapnea, where the patient, if patient takes a deep breath and increases the tidal volume, that probably helps in the alveolar ventilation and hypoxemia. So when we put this into our algorithm, our indications changed, and currently our indications remain that anyone who requires more than 40% venturi to maintain target saturations. Again, the target saturations have moved quite a bit during the first wave of the COVID pandemic. Our initial indications were more than 95%. Then reviewing literature in ARDS patients in the past, including randomized controlled studies, showed that modest or more accurate saturation targets of 92 to 95 had better outcomes compared to hyperoxygenating them. So if a patient would not achieve the targets on 40% venturi, which is a SpO2 of less than 92% or a PaO2 of 70 millimeter of mercury when someone has type 1 respiratory failure, or the targets go down further if it is a type 2 respiratory failure, for example, COPD with hypercarbia, then the SpO2 targets would be 82% and PaO2 targets would be 55 millimeter of mercury. The second standalone indication for NIV would be someone who has increased work of breathing, as noticed by a prominent sternocleidomastoid contraction with any even minimal oxygen requirement would benefit from NIV. This is because if we do not correct that cycle of increased breathing causing an inflammatory trigger within the lung parenchyma, it will lead on to a cycle where these patients go on into more inflammatory response, auto-triggered worsening of ARDS. So when a step ahead is when we need to consider ARDS, consider NIV in COVID when these patients have increased work of breathing, or when the saturated oxygen requirement is about 35 to 40% of venturi to maintain targets, is when we need to consider NIV. This is the algorithm which we follow in our level 2 wards. So patients who are hypoxemic are started on oxygen either by nasal cannula or through venturi. And very much as the onset, two things need to be thought of. One is the escalation plan for the patient, because based on this, whether the patient is for ward-based care, NIV as ceiling of care or all out. It determines how we are going to move and shift the patient. So that needs to be decided. And the other thing that is found to be helpful is awake self-positioning, or what most people would call awake proning, because this is known to decrease the ventilation perfusion mismatch. And when patients are prone, more alveoli are recruited, and it improves the oxygenation. So that is started in the level 2 wards at the very beginning. And when the oxygen requirements go up to 35% venturi or 4 liters by nasal cannula, is when, if they are for NIV as ceiling of care or for full escalation, they are considered for non-invasive ventilation and referred appropriately. If they are not for full escalation or even NIV as ceiling of care, then the oxygen would be sequentially improved up to a reservoir bag with 15 liters of oxygen. Now, the contraindications of NIV remain the same as for non-COVID indications. An absolute contraindication would be a GCS of 8/15, a respiratory arrest, significant upper GI bleed, uncontrolled bleeding, upper airway obstruction, facial trauma, and a rapid patient decline. Relative contraindications would be hemodynamic instability, and agitated, uncooperative patient, recent upper GI surgery, pregnancy, or orofacial abnormalities. The relative contraindications can be overcome by sedation, by using different interfaces which can overcome orofacial abnormalities in administering NIV. Going on to the how to do or how not to do, probably we need to understand some basics in administering NIV. So we will look at the pressures and modes through which we can give NIV. So this graph has time in the x-axis and pressure in the y-axis. And in the pressure graph at the start, we see the EPAP, which is the expiratory positive airway pressure, or otherwise called the PEEP, which is the positive end expiratory pressure. That is what keeps the alveoli open during expiration. Now, during inspiration, if it is a triggered breath, the pressures probably drop slightly. If it is a machine-delivered breath, there is no trigger, as we see in the prior to the second box. Then there is a rise, which is determined, the steep of which is determined by the ramp setting. That is how fast you reach the inspiratory positive airway pressure, which is the topmost pressure one would reach during the inspiratory cycle. And the difference between the inspiratory positive airway pressure and the expiratory positive airway pressure is the pressure support. Now, understanding it in a easier way would be breathing is not static. There is an inspiration and expiration. Again, time in the x-axis, pressure in the y-axis. What we see in the first picture in the left bottom is the normal breathing. When we put a patient on CPAP, the baseline EPAP is elevated, and there is a tidal breathing that's going on top of that. When we give a bilevel positive airway pressure, we increase the pressure support, or the difference between the IPAP and the EPAP, and we are able to give a higher pressure during inspiration and maintain the EPAP during expiration. Now, there are various modes by which NIV can be delivered, and this is important to understand because each setup may have various combinations of these, or probably one of these. There are some mission hospitals which have only ventilator and have to use the NIV mode of the ventilator. There are certain setups which have only BiPAP machines and they need to use that. So touching upon three of these, which is the BPAP, the CPAP, and the NIV mode of ventilator. The BPAP is the conventional bilevel positive airway machine. So this is not a ventilator. This is a standalone machine. It is able to give a EPAP, which is the same as PEEP in a ventilator, and the IPAP, which is a summation of the EPAP and the pressure support, if you talk in ventilator terms. And IPAP minus EPAP would be the pressure support. Here you have a machine which is delivering pressure, which is driven primarily by air, and oxygen is entrained into the machine. So when oxygen is entrained into it, it mixes with the pressurized air that is going through the tubings and gets delivered to the patient. So the disadvantages are you cannot know the exact FiO2. But you can know by putting a FiO2 meter, you can measure, but that's generally not available, so you do not know. We have worked out some calculations as to what pressures, what flow can give what oxygen. But what is important to note is that you can give only a maximum FiO2 of about 50%. And this also, when the pressure support increases, when the IPAP minus EPAP, when you're giving more pressures, less oxygen will mingle into the stream. This is like when you're going in traffic, if you are trying to enter a very busy road, you will take more time to enter. So in that way, less oxygen diffuses into the pressurized air. So more the pressure, lower the FiO2. Moving on to the CPAP mode, this is similar to the BPAP, but can give only PEEP. PEEP by itself is probably enough in a significant proportion of patients, and there are centers, particularly in the UK, which have used only CPAP during the first wave of the pandemic. So this comes as the manual CPAP. This is much less costly. So it can be got at around 35 to 40%. This is commonly available because it's used for obstructive sleep apnea, which is reasonably common. Here again, you give oxygen entrained into a pressurized air. So here again, with a conventional CPAP machine, we can give only up to a FiO2 of 50%. But if we add on some PEEP valves, which certain devices allow, or we can devise valves, which we have tried to do, we can give up to FiO2 of 100%. Moving on to the NIV mode of the ventilator, this can give the conventional PEEP and the pressure support, and it can give a FiO2 up to 100% because it has got a oxygen blender inside the ventilator. But to note, all ventilators do not have the CPAP mode, and giving CPAP alone by just decreasing the pressure support to 0 may not work exactly like how the CPAP mode of a ventilator works. So these things need to be kept in mind. Moving on to interfaces, there are several interfaces how these machines deliver pressure into the airways. The first one is just a oronasal pillow. This is hardly used. The second one is the oronasal mask, which is more commonly used. So everyone is comfortable using it. Important point to note is that the mask should be non-vented. Normally, we are used to using vented masks where exhalation port is in the mask. Here, we should use a non-vented mask because you do not want unfiltered virus particles to go into the atmosphere to increase healthcare worker risk of acquiring COVID. Then moving on to the full face mask, which we see as the third one here. Again, because of irritation and flow into the eye, it is not a preferred mode. The helmet is a mode that has been projected to have less aerosol dispersion, safer for healthcare worker, and better patient comfort. So we have tried it in a reasonable number of patients during the first wave of pandemic, but it has its own limitations in terms of connections to the BPAP machine, the ventilator, and so on, and people are not familiar to use this. So unless you're geared to go that way, that may not be the right option. So the oronasal mask will be the conventional mode of delivery. In all this, it's important that the bacterial viral filter is there between the interface and the exhalation port, so that the air that is expired out is filtered before it enters the atmosphere. Along the same lines, few tips is we need to set the machine before it is connected onto the patient. Sometimes we may, in pre-COVID times, we may put the mask and then set. All that increases aerosolization of virus into the atmosphere. So always set everything before you put on to the patient. And also only after putting on to the patient, we should switch on the machine. Again, for same reasons, and we should have the BV filter. So this is how the mask and the BV filter exhalation port. So when connected, we should have the mask, then the oxygen port, then the BV filter. The exhalation port should come after that. There are few requirements before starting NIV. We should do a chest X-ray to rule out pneumothorax, which is an absolute contraindication to NIV. And it's useful to have a baseline at NIV initiation to see how the patient progresses in case there is a decline. An ABG is also useful to know the PF ratio and the metabolic status. And very importantly, when initiating a patient on NIV, we should have the ceiling of care available. Only then we'll know how far to go and when to refer to critical care or invasive mechanical ventilation. This is a flowchart for standalone BiPAP machine, which has been fine-tuned during the first wave of the pandemic So we start with the initial flow of 15 liters per minute because these patients come in type 1 respiratory failure with a PEEP of 6 to start with. The saturation target is 92 and a workout breathing which is settled. If these two are not achieved, one would incrementally use 2 centimeter PEEP every half an hour to reach a maximum of 10 centimeter. At whichever point the patient stabilizes, 30 minutes later, we would do a ABG. And at 30 minutes ABG, again, there are 3 targets we are looking at. One is the SpO2 more than or equal to 90, a PaO2 more than or equal to 70, and no increased work of breathing. If this is achieved, then we would continue on the same and now target the SpO2 and decrease down titrate the oxygen requirement, which is very important in these times where the quantum of oxygen we use is important to conserve oxygen. And then we do a ABG after 4 hours and ensure we are in target range of PaO2. In case on the right side, any of the targets are not met, then we add on pressure support. So if the patient has reached 10 centimeter of PEEP, we would add on a pressure support of 6, which would amount to 16 by 10 on a conventional BiPAP. And again, incremental pressure support of 2, that is to 18, a maximum of 20 by 10 is where we would reach to attain the targets. If at that point targets are not achieved and if the patient is for full escalation, needs to be referred for critical care. That is saying the same thing. Again, reiterating on the targets, the SpO2 is more than or equal 92 to 95, no increased work of breathing, and a PaO2 of between 70 and 90 whenever a ABG is available. Few troubleshooting points. One problem can be excessive leak. This can be because of problems in the tubing connection, in the fitting. If you have not chosen the appropriate size of mask to the patient, that can be a problem. And there can be leaks along the tubes, which also need to be addressed. Drop in saturation can be a problem where there can be a problem at the flow meter level, oxygen coming in, or it can be at the connection between the oxygen tubing and the circuit, or it can be problem with the interface. So if all these are checked, then we need to increase the supply of oxygen to the patient or the PEEP, which will increase oxygenation. And obviously at this time, we would start looking at clinical causes of desaturation. Worsening of tachypnea or respiratory distress, again, we need to check the oxygen and the flow and troubleshoot as in the above 2 sections. We need to check for leak and troubleshoot that. We need to check if the BiPAP machine is working, check the tubings, check the interface, and check for leaks in the entire circuit. Tachypnea, as I alluded to previously, is multifactorial. There is stretch receptors, there are mechanoreceptors, chemoreceptors, there is an anxiety problem where people are seeing everyone with PPE. All this adds on to tachypnea. That's why it's important that you don't act on tachypnea and increase oxygenation. One of the problems that we have faced on a practical front is patients who are not tolerating NIV, and they may not be for full escalation or may not require that much pressures or oxygen, but we are not able to handle them on the NIV. So though all patients do not require sedation, it is useful in a important subset where they do not tolerate, very high pressures are required, or they are anxious. The commonest and well tolerated with least respiratory depression is dexmedetomidine, which is used as 5 mics to 30 mics per hour infusion. It comes as a 200 mics per 2 ml ampule. When diluted in 48 ml NS, it gives 4 mics per ml. So we would start at 1.2 ml per hour with that dilution, and we can escalate as required. Fentanyl can be added on to alleviate pain. Midazolam can be an alternate to dexmed, but has a problem of respiratory depression. Going on to the weaning protocol, weaning needs to be initiated when the patient is stable for 24 hours on the settings of NIV. General weaning protocol that we follow are, we start with a 3:1 spacing. By that we mean 3 hours of NIV and 1 hour of Venturi. This is subsequently changed to 2:2, 1:2, and then only Venturi. Every step down is after observation of 24 hours in the previous settings, and once stable on Venturi for 24 hours, they can be stepped down to a level 2 ward. Weaning from oxygen is also very important at this point in time. Probably best not to wean till the first ABG is done. After that, it can be weaned to achieve saturation targets 92 to 95 in type 1 and 88 to 92 in type 2 respiratory failure. ICU referral criteria is very important when patients are on NIV and despite maximum supports, their saturation is less than 92 or there's increased work of breathing, they need to be referred. If someone is not tolerating NIV and clinically deteriorating without it, then they need to be referred. A decreased sensorium, hemodynamic instability, multi-organ involvement would require referral if they are for full escalation. Couple of points before I conclude with an adjuvant and a caution. The adjuvant is awake self-positioning. So all patients on NIV are preferably need to be rotated self or assisted over a period. So every 30 minutes to 2 hours, we put them in prone, right lateral, supine, or sitting up. And if you have a chart and make this documented, it's very effective. When rotating, care of tubing need to be taken, otherwise it can get rotated, disconnected, and so on. It's also important to educate the patient on the benefit with this. Otherwise, the patient feels, why should I be doing it? But the patient understands that this is going to change their outcome, that this will prevent them from worsening, going to ICU. Then there is a lot of cooperation in doing it. My final point is on conserving oxygen during this acute shortage of oxygen in many parts of the country. So few tips to save oxygen are, we should ensure that oxygen is started only when it is indicated. So the target saturation is 92 to 95. So unless saturations go below 92, there is no need for oxygen. In a lot of places when saturation is 93, 94, they start a lot of oxygen. This wastes resources. Secondly, once oxygen is started or patient is on NIV, we need to ensure saturation targets are maintained. Hyperoxygenating the patient has detrimental effects as well as wastes oxygen. Avoid HFNC, which consumes high flow. So about 40 to 60 liters of oxygen is required to give this mode of ventilation. So probably in this time, it is best avoided. And yesterday, Dr. Kishore had put a message in the group, which was very useful, where he brought out this article, which says that if you use reservoir bag with lower flow, you can give higher FiO2. So like if you normally for a 40% Venturi, you need 10 liters. For a 60% Venturi, you need 15 liters. So if you put a reservoir bag and give 6 liters, you can give the same thing which the Venturi can give with 15 liters. But the problem is there can be flow starvation. So I think this is a good mode which can be used. And if there is flow starvation represented by after doing that, the patient is tachypneic, increased work of breathing, we can always shift back. So with that, I would conclude. If we need any further help and training, there are modules that have been made by the CCC training group, which are available. So if you email them on this email, they would be happy to put you through that. So thank you very much. In this second wave, which is raging large, I'm sure with the help of God who enabled us to go through the first pandemic, we can go through a difficult challenge as well. Thank you for this opportunity.
Thank you, Barney. We will take the questions at the end of the second talk. I'll invite Dr. Binila to.
Good morning to everybody. I'm here to tell you about the medical ICU experience on how we managed COVID ARDS, or what is better known as CARDS nowadays. Before I start, I have a few disclaimers to make. The first thing is one size does not fit all. And while you may be looking very carefully at this presentation, and one thing you must remember is that you will need to tailor management according to each individual patient. This protocol that we put down in these presentations may work for most patients. Most of the management protocols that we are using in the ICU is based on rudimentary evidence, logic, and some scientific intuition. And as we speak every day, there are numerous trials which are coming up, and the world is still learning, we are still learning, and this presentation is mainly based on the medical ICU experience with COVID ARDS. The past 1 year has gone by so fast. I can't even believe that it's almost 1 year since we got our first COVID patient. We've managed close to 900 patients of COVID ARDS in the ICU so far. So in this presentation, I mean, like when I look back last year, I still remember talking to some of my colleagues saying that this is no different from any other ARDS. But over the past 1 year, I've changed my point of view, and this is based on certain pathophysiological mechanisms which have been described, and on which ventilatory strategies and medical management differs from the usual ARDS patients. So since we have people from different backgrounds who are attending this presentation, I thought I'll just very quickly take you through the Berlin's definition of ARDS. In fact, actually, a lot of the patients' relatives who call up, they're very familiar with things like PF ratio and PEEP. So just to make sure all of us are also on the same page, ARDS is said to happen if you have an oxygenation abnormality, which is defined as a partial pressure of FI of oxygen by the fraction of inspired oxygen being less than 300 in a ventilated patient with a PEEP of at least more than 5 centimeters of water. And this respiratory distress should happen within a week of a known clinical insult, with a chest X-ray showing bilateral opacities, which are not completely explained by other pathologies. Based on the PF ratios, patients are categorized as having mild, moderate, and severe ARDS, with severe ARDS having a PF ratio of less than 100. Now, before I go into the COVID ARDS lung, I just want to take you through this typical ARDS lung, which, as you can see here, starts off with the alveolar macrophage being activated. And there's a cascade of inflammatory mechanisms which come into play. And this results in actually damage to the alveolar and the capillary membrane. And with the damage to the alveolar capillary membrane, you've got interstitial edema, you've got alveolar edema, you've got a lot of inflammation within the alveolus. And all this inflammation and swelling within the alveoli kind of press on the other normal alveoli in dependent areas, and there is collapse. Now again, some terminologies which is pure ICU lingo, but I will be referring to it during the talk. ARDS lung is actually very heterogeneous, so it's not the same throughout. You've got the baby lung. Babies can't be wrong, so baby lung refers to the lung which is the most ventilatable, well aerated tissues. And then you've got the consolidated lung, where there is some inflammation which is sitting there. And this consolidated lung sits down and presses on with edema and causes some atelectasis and collapse, resulting in what we know as the non-cardiogenic pulmonary edema, or ARDS. Now, one thing which we see very commonly in ARDS is shunting. And what I refer to as, what I mean by shunting is, you can see this, alveolus, which is collapsed. You've got the capillaries which are around this alveolus. And these capillaries, obviously there's shunting of blood past this alveolus without adequate gas exchange. And so this is what we refer to as shunt-related hypoxemia, or shunting of blood past alveoli which do not participate in ventilation. And over time, with the inflammation, this baby lung or ventilatable lung that we see here actually decreases in size, and there's a drop in lung compliance. That means the lungs become very stiff. Normal lung compliance and respiratory system compliance works out to be about 100 ml per centimeter water. So with ARDS, very bad ARDS, it can drop to even less than 30, 20, or even 10 centimeters, 10 ml per centimeter water. So is COVID ARDS any different? I think the first thing to say is, as I mentioned earlier, ARDS traditional definition is ARDS should happen within a week of insult. We all know that COVID ARDS, the symptoms tend to happen 7 days after the onset of the original symptoms, and ARDS happens about 2.5 days after the onset of dyspnea. Now, COVID ARDS, is it any different? I mean, if you look at the lung per se, what they found is there's a discordance between the lung mechanics and the arterial hypoxemia. So patients are hypoxemic, but their lungs are actually have got a relatively good compliance. They can expand quite easily. Minute ventilation is very high. And numerous CTs, thousands and millions of CTs have been done the past 1 year. And we know that the predominant findings in the CTs is ground glass appearance, which is typical of interstitial edema. So we are already seeing a lot of changes from the typical ARDS, where you've got poor compliance, drop in compliance, you've got a lot of alveolar and interstitial edema, whereas this tends to be more interstitial and the compliance is good. In addition, what has been observed from postmortem studies is there's a disproportionate endothelial damage. And what does this do? So this normally when all of us become hypoxic, our capillaries tends to vasoconstrict. That's what we call the hypoxic pulmonary vasoconstriction. With ARDS of any sort, not just COVID, but any sort, there is a loss of hypoxic pulmonary vasoconstriction. And when the vessels do not vasoconstrict, you've got a lot of blood again shunting past alveoli, which are not performing their gas exchange and they work properly. And that aggravates the ventilation perfusion mismatch and the shunting hypoxemia. And this, because of the endothelial damage, there are some reports that this could foster thrombogenesis, as you can see here, where you have actually thrombus sitting within the pulmonary vessels. Now, this article by Gattinoni actually shows that there is these lungs have a good compliance. What you can see here with a compliance of about 50 ml per centimeter water, which is fairly good for an ARDS, and a huge amount of shunt fraction. Normally, in all our lungs, we have about 10% shunt fraction. This has shunt fractions even close to 0.5. So there's a wide disparity between the compliance and the shunt fraction, which we normally don't see and which is unusual for most ARDS. Again, this, I have taken this in my previous presentation. Well, these are the typical COVID ARDS phenotypes. You've got the L-type phenotype, where the lungs are actually very compliant. They can expand easily and can also relax fairly well. They have a low lung weight. That means the lung water is very minimal. And essentially these, because most of the alveoli are already well aerated, they have low lung recruitability. As opposed to the H-type phenotype, which is actually our typical ARDS, what we see normally, you have low compliance. The lungs are very, very stiff. There's a lot of water within the lung. But these lungs are much better recruitable. That is with PEEP, the response is much better in this type lung as opposed to the L-type lung. Now, I will be taking you through the different management principles based on this pathophysiology in the next few slides. Coming to the ventilatory strategies, again, I'm going to show you what happens in normal ARDS and then what we are doing in COVID ARDS. Now, this is a very famous study called the Lung Safe study, where they actually studied ARDS and different ventilation modes. And what you can see here, they used NIV in about 15% of patients with ARDS, and the failure rates that were reported was up to, in all patients, about 1 in 3 patients failed. More patients were likely to fail in the patients with severe ARDS. And not just that, they actually found that NIV use in ARDS was associated with higher ICU mortality. And that's why most intensivists are very cautious about using NIV with ARDS. The other traditional things which we talk about for ARDS is maintaining a low tidal volume of, once the patient is intubated, of 4 to 8 ml per kilogram predicted body weight. Plateau pressures refers to the pressures within the alveolus. What comes on most ventilators with what you see is the peak pressures, and a rule of thumb is the plateau pressures tends to be about 5 centimeters less or 2 to 5 centimeters less than the peak pressures that you see on every ventilator. So maintain plateau pressures less than 30 centimeters of water. And this strategy has been shown to decrease mortality. And our targets should be permissive hypoxemia. Just give enough oxygen to maintain adequate tissue perfusion, and permissive hypercapnia with a pH target of more than 7.15. So is there a role for NIV in COVID ARDS? The last time I gave this talk here, I said that we were very scared to give NIV in COVID ARDS, mainly because of the aerosolization. We don't have negative pressure rooms. That was a major source of concern for us, but we did see benefit in a few patients, and we decided to go ahead and try it out. So Barney has already covered it in great detail. Most of the time, what we see patients need, as I said, they have huge lung volumes. They don't need much pressure support. All they need is PEEP. We use viral filters both at the patient end and at the ventilator end to decrease aerosol transmission. And all patients are encouraged to prone. Now, they can't self-prone because they're quite sick, but our nurses and attenders and sweeper, everyone has become quite skilled at proning patients. So this is we try and encourage at least 12 hours of 9 to 12 hours of proning every day. Now, this is our data. This is from the first 6 months of our data, where we studied, looked at the patients who were admitted with COVID ARDS. As I said, we started seeing a benefit with NIV, and we've been using NIV quite rampantly for patients with COVID ARDS. You can see that of the 333 patients with COVID ARDS, 85% were actually started as the first line of therapy with NIV. And NIV was successful. And when I say successful, they were managed alone with NIV. They were discharged home, sent back home without any intubation ventilation in about 2/3 of these patients. 1/3 of the patients failed NIV, that is, they required intubation or died. And I just want to highlight also that we have used NIV across all types of respiratory failure, whether it's mild, moderate, or severe ARDS. You can see that, moderate ARDS contributed the major chunk, but, it's almost like a 50-50, maybe a 40-30-30 among the mild, moderate, severe ARDS category in terms of the NIV usage. What we found was the patients who were more likely to fail NIV were the patients who had a higher disease severity, who used NIV for longer periods of time, patients who required inotropes or dialysis. I must tell you that most of our patients who came into ICU only had pure respiratory failure. The inotropes or dialysis came in only when the patients had a secondary infections. And also the peak D-dimer more than 1,000 was associated with a high risk of failure. So now we've seen how to use NIV in Barney's talk. As I said, we are using NIV for a lot of our patients with COVID ARDS, but there's always this big question in our mind: when should we intubate the patients? And this is mainly based on clinician judgment. Just to name a few factors: saturation, whether the patient has got increasing FiO2 requirement, drop in GCS, work of breathing. And when I say work of breathing, not just the respiratory rate. Now, examining patients or auscultating patients is very difficult. Good, look at the patient, see if they have accessory muscle of use, see if the sternocleidomastoids is being used, and all those should be surrogates for telling the clinician when to intubate the patient. Now, and this whole thing about increased work of breathing causing injury is because of this concept of self-inflicted lung injury, where you have patients who are hypoxemic. If they are not settling down with the support that you give them, let's say you're putting them on NIV, they don't settle down, they have vigorous inspiratory effort that results in self-inflicted lung injury, which in turn sets a cascade of more events. You have more edema, more inflammation, more thrombosis, and that baby lung, which I said earlier, that becomes even less and less, and the hypoxemia worsens. So in fact, people have, or experts around the world have suggested that we should actually intubate patients early rather than putting them through this cascade of self-inflicted lung injury. And so the targets are essentially to look to target hypoxemia and to watch for vigorous inspiratory effort. So when is the right time to actually intubate? You don't want to be late. You want to be right on time, bang on time when you are actually going to decide upon intubation. We actually burnt our fingers the past 1 year with a few patients where, they actually look quite well. They're like breathing at 20 to 25 breaths a minute. Their FiO2 requirement is going up, but you feel so sorry to intubate them because their work of breathing doesn't go up. But those patients, when we intubated them late, like 70–80%, they just crashed immediately after intubation, and many of them died. So again, based on the study that we saw, just to kind of highlight that this group, which is marked in blue, is actually the group which survived with just NIV alone. The group marked in red are the people who failed NIV and died. And you've got the group in green who are actually intubated. And what we see here is the time to intubation seems to make a difference. Now, in the group which failed and survived, they seem to be intubated much earlier. So my suggestion is, and this is what we are following for this year, the pandemic, is to try and make a decision early. By about day 3, you take a call. Do you want to keep the patient NIV? Is it making a difference for the patient? Is the patient's PF ratio getting better? Work of breathing coming down, FiO2 coming down? Then fine, you continue NIV. But if that's not the situation, you may have to go and intubate the patient earlier. There seems to be a trend or tendency or a trend towards better survival in patients who are intubated early. So just to take you through, now we've heard about 2 types of lungs. You've got the good compliance lungs and you've got the poor compliance lungs. The poor compliance lungs, or the H-type lungs, are the lungs which need to be managed like any other standard ARDS. But the principles of ARDS remain the same. You need to achieve safe volumes, tidal volumes of 4 to 8 ml per kilogram of the predicted body weight. You need to make sure that the plateau pressures, that is the pressures at the alveolar level, are safe, less than 30 centimeters of water. The only difference is, now I already told you that the lungs in the good compliant lungs, they're actually not very recruitable. The alveoli are already distended. The problem is mainly to do with the vessels. You've got a lot of shunting of blood. Do not use too much of PEEP. It will actually over distend the alveoli and can cause even compression of the capillaries and dead space. So what they recommend for the good compliance lung is use PEEP of 8 to 10 centimeters of water. What it does, it just kind of, you've got the alveolus there. It compresses the vessels which have a lot of blood flow and redistributes perfusion in response to pressure and gravitational forces, as opposed to poor compliance lung, where you may even use 10 to 14 centimeters of PEEP and you'll use conventional ARDS strategies. Now, there always used to be the debate as to whether to paralyze or not paralyze. For a traditional ARDS, as long as you can achieve good patient ventilator synchrony, there is no clear-cut evidence to recommend routine paralysis. But what we have found, again, this is based on our experience in the past 1 year, we have found that to achieve targets of low tidal volumes, to make sure, because those lungs are highly compliant, you'll get volumes of 700, 800 ml. To achieve those targets, safety targets, we've had to use good amount of sedation and sometimes even paralysis. And the patients who've been paralyzed, we yet to do the full analysis, have seemed to have done much better than the patients who were paralyzed for much shorter periods of time or not paralyzed at all. So this is again just to show you the lungs. This is what I mentioned here is the peak pressure is what you will see on the ventilator. Plateau pressures tend to be about 4 to 5 centimeters less than this. This is how an L-type lung would look like. Huge tidal volumes, it's unsafe, and the peak pressures or plateau pressures will actually be low. As opposed to a lung like this, which is a very stiff lung. You've got high peak pressures, plateau pressures also on the higher side when we checked it. There are techniques where you can check the plateau pressures in the ventilator with an end inspiratory pause. And you can see that this lung is much stiffer. This kind of a lung should be managed with standard ventilatory management. This kind of a lung, don't increase the PEEP too much. The lungs are already quite well aerated. So a stepwise approach is to recap what we said. You've got a hypoxemic patient, give oxygen or high flow. We are not using high flow right now because of the shortage, as Barney mentioned. Consider NIV early, especially in patients where the work of breathing is high, and proning for all patients. In patients who have an increased work of breathing, with or without increasing FiO2, intubate early, as I showed you in the graph, preferably earlier, maybe about 3 to 5 days. Don't delay intubation. PEEP setting depends on the lung compliance. You've got very compliant lungs, use PEEPs of 8 to 10 centimeters of water. You may need neuromuscular blockers to decrease self-inflicted lung injury and continue proning. Okay, And this is the algorithm that we developed last year and which we fine-tuned over the years. You can see here that we use NIV for all grades of an ARDS, whether it's mild, moderate, or severe. In this group of patients with mild ARDS, if the work of breathing is high, we put them on intermittent NIV. In moderate ARDS, we start them off with continuous NIV and we assess their response and we decide on intubation, as I mentioned earlier. And the similar thing with severe ARDS, we actually do a continuous NIV trial, but some patients may need immediate intubation. We have used ECMO for some patients where they've not been able to ventilate them as of now in about 3 to 4 patients. One word of caution I'd like to mention here is that group of patients where their respiratory rate may sit at 20 to 25, but the FiO2 is going up. Please don't delay intubation in that group of patients. You have to go ahead and intubate them, control their ventilation, and prone them and position them appropriately. One thing which we always advise the registrars as they go around on rounds is to examine patients for pneumo-mediastinum. Not sure whether the picture is very clear, but you can see that this is a patient who's in the ICU right now. You can see all the spectralis muscles and all very, very clear. You've got tracking of air into the subcutaneous tissue. How do you manage this? You don't have to put chest tubes. All you need to do is just conservative management, put them on 100% FiO2, low PEEP, we brought it down to 5, or maybe even just keep them on a reservoir bag. And you can see now that pneumo-mediastinum has improved. Unless the patient develops a pneumothorax, please don't go and put tubes into the subcutaneous tissues. Medical management, I'm going to very briefly cover because Dr. Osi has already covered it in the last talk. Dexamethasone, we know, is recommended for all patients who require oxygen or more. When patients do not need oxygen, there is no indication of dexamethasone. So dexamethasone 6 mg IVOD, this is the recovery trial, and subsequently meta-analysis has looked and pooled together all the data. And you can see here that even over hydrocot and methylpred, Dexa seems to be faring much better with a survival benefit. So please make sure that you start all patients in ICU on dexamethasone. One thing we need to say is there are 2 trials, the ACT-1 trial and the Solidarity trial, both of which have not shown a mortality benefit. So there is no mortality benefit of using remdesivir. What is the benefit that has been shown? It has been shown that it decreases time to recovery in patients requiring oxygen. You can see here patients who are on NIV, there is no evidence of benefit. So again here, no mortality benefit. Once patients are in ICU, there's probably no point putting on them on it. If at all, you should use it early when they are on oxygen. Now, anticoagulation, a very controversial topic where there's a lot of discussion. You can have debates about it. The theory behind the need is because you have incidence of thromboembolism as high as 1 in 3 patients from reports. And in ICU patients, there's a 4-fold higher incidence, 28% versus 7%. Plus, there are post-mortem studies which have shown microvascular thrombosis. In the study, you can see that the predominant clot is actually a platelet fibrin thrombi. And that is why people are looking at not just thrombotic agents, but antiplatelet agents as well, anticoagulants and antiplatelets and thrombolysis. All paths are being studied. You can see here, this is a beautiful article which describes the ongoing study. So there are 33 ongoing trials looking at antithrombotic therapy, different aspects, anticoagulation, antiplatelet, thrombolysis of various sizes, quite fairly big studies. But I'm sure all of you are aware that the 3 major studies showed tendency towards harm more than benefit in critically ill patients, and the study was stopped in that group of patients. There is evidence that there is some evidence to suggest, but the full report hasn't come out yet, that moderately ill patients, it may decrease ventilatory or organ support. When you say moderately ill COVID patients, these are patients who have saturations of 94%, not requiring oxygen. But I'm going to tell you exactly what we practice here in the ICU. We are therapeutically anticoagulating patients when D-dimers is more than 1,000. If there are no contraindications, our preferred drug is low molecular weight heparin. We have not had major or very significant major minor bleeds. It's been about 1% in our cohort of 900 patients. And the duration is a minimal duration of 14 days, and it should be followed up by prophylactic anticoagulation. We have had patients who have developed clots even while on anticoagulation. If there's a deteriorating COVID patient, there are several reasons which could come up, from the standard ICU problems of infection, collapse, pneumothorax, tube block, or it could be COVID related, where you could have an inflammation, cytokine storm, thromboembolism, or fibrosis. And this is where the immunomodulators, tocilizumab comes up, plasma exchange comes up, convalescent plasma comes up, and people are looking at the role of thrombolysis as well. For fibrosis, as of now, there is no magic therapy. Dr. Osi has covered this. One slide just to say that tocilizumab, based on these, several studies have been done, 6 to 8 RCTs have been come out, but the major trials which have come out are the REMAP-CAP and the recovery trial, which have shown benefit in patients. And so the NIH has recommended the use of tocilizumab, a single IV dose of 8 mg per kilogram in combination with dexamethasone in patients who are exhibiting rapid respiratory decompensation. But be careful, avoid tocilizumab in patients with immunosuppression, patients with liver enzymes are more than 5 times the normal, who have a high risk of bleeding, uncontrolled infection, neutrophil count less than 500, or low platelet count. Now, is there a role for plasma therapy in COVID-19 convalescent plasma? No role. The PLACID trial has come out. Plasma exchange, there are RCTs which are ongoing. People have considered it as a rescue therapy for patients who are not improving despite conventional therapy, but most of the reports of benefit are based from retrospective cohorts, and we have used it as rescue therapy in a few patients. Now, supportive care is extremely important for all patients in the ICU. Continue feeding, appropriate analgesia, sedation, and make sure your patients are dry. We know that the vessels seem to have a major problem. So ensuring that the patients are dry, fluid balance is neutral, diuresis when indicated, that's very, very important. Now, these are our patients who have come in over the past 1 year. It's a little scary because I don't know what to expect over the next few months. But, God has been good. This is, again, that same cohort where I've shown that we use NIV for about 86% of our patients. Our overall mortality, by God's grace, was only 33%. NIV mortality was 30.1%. There were about 22 of these patients who had non-escalations which were put in place. Among the patients who intubated, what we tend to tell our patients who come in is it's a 50%. It's a gamble, which is almost, when we compare it with moderate severe ARDS, our mortalities are almost the same with any other ARDS at this point of time in our ICU. So COVID ARDS, just to summarize, is not a typical ARDS syndrome. We have relatively good compliant lungs. The problem seems to be in the circulation with a lot of shunting of blood and shunt-related hypoxemia. In terms of ventilatory management, please use NIV. Give patients a trial of NIV as much as possible, but do not delay intubation. If you see a patient struggling, gasping, worker breathing high, or even in patients where the F2 is going up but the worker breathing is low, do not delay intubation, preferably beyond 3 days. In patients with good compliance lung, PEEPs of 8 to 10 centimeters of water, there may be a role for neuromuscular blocking agents in patients who have who have to decrease self-inflicted lung injury, and in patients with poor compliance, follow conventional ARDS strategy. In terms of medical management, dexamethasone for all patients with COVID acute respiratory failure. Remdesivir, there is no mortality benefit. Tocilizumab, there may be a role in patients with rapid deterioration. Therapeutic anticoagulation for patients with D-dimers more than 1,000. So I'll stop here. This is the team of faculty who have helped us, and there are lots more. Actually, we need to add to our team. Dr. J.V. Peter is also part of the team right now. And the nice thing is everyone has been so positive in this time. God has been good. He's protected us despite our rampant use of NIV. Only 3% of our staff were COVID positive. No one was seriously ill. And we look to him for further protection this year as we face the pandemic. Thank you.
Thank you, Dr. Barney and Binila. Before I open the session for question and answer session, I will request if Dr. J.V. Peter, our director, is available. I see that he has been actively participating and answering many comments in the chat box. We are privileged to have him. He is intensivist by heart. We are privileged to have him at the helm of affairs during this pandemic. Sir, are you there? If you want to make any comments.
Dr. Balamugesh,
yeah.
Thank you for asking me to speak. I think these two presentations were excellent. And what it exemplifies is that there is so much of learning at the bedside. That's what research is all about. You observe how patients behave and you titrate and modulate your treatment protocols based on your experience with several patients. And this is so true about COVID. And I have personally also felt that having gone in and seen these patients, they are much different from the standard ARDS patients. And I'm sure over the next few months, we'll have a lot more evidence that will help our patients and we will have better outcomes. So I'll stop here because we are already over time.
I'll request Kripa. She has compiled all the questions and the comments, and our panelists will answer these questions.
Thank you, sir. We've had many questions about differentiating good versus poor compliant lungs. You can ask Dr. Binila to answer that.
That's why actually I put up that picture of the ventilator, just so that all of you can get an idea, or you can actually make out when you put patients on the ventilator, whether the lungs are compliant or not. When you see that they've got huge tidal volumes, that's very unusual for a patient with ARDS. ARDS lungs are typically low compliance. They have, much smaller lung volumes. They tend to be more tachypnic and small lung volumes. So that is how you can, if I can maybe just put that slide back, just to kind of, is it okay? To just show that. So this is how it looks like. You will have patients who have got, you set the tidal volumes at 360 here, but look at the volumes that are being generated. So that is huge. So you can get that by just looking at the patient, seeing their work of breathing, seeing how their lungs move. Is it being projected?
Thank you, ma'am. There was another question on how to ensure that the plateau pressures stay below 30.
So that's a separate ARDS class altogether. But if you have, so the main thing is when you have safe volumes of 4 to 8 ml per kilogram, there are times when that itself can cause high pressures in the lung. So people have looked at, when you control, you could control the pressures as well with a pressure control mode of ventilation. And when you control pressures with a pressure control mode of ventilation, you can ensure that the plateau pressure remains at 30 or less. Now that comes with the compromise of you're setting a fixed pressure. The tidal volumes in a stiff lung may be much lower, and the patient may have a problem with compromised minute ventilation, and the carbon dioxide can actually go up. So you can control the plateau pressures in patients. And as I said, other strategies like paralysis helps in making sure that the patient is not fighting against the ventilator, improving ventilator patient synchrony.
There's another question on using the Chacko scoring system to predict NIV failure, whether we are using it.
No, we are not using that for predicting NIV failure. Essentially, it's more a hands-on bedside thing. You go look at them every day and you make a decision based on the parameters that I mentioned earlier, the PF ratios, FiO2, work of breathing. That's what we've been using.
Thank you, ma'am. Dr. Barney, there's a question on how to assess and measure work of breathing.
Yeah, so as we were discussing, measuring of work of breathing is not easy when the patient is on NIV, fully covered. So the most consistent evidence has shown that the consistent parameter which relates to work of breathing is a prominent contraction of the sternocleidomastoid. So that neck is usually exposed. So looking at the sternocleidomastoid and assessing the accessory muscles of respiration is probably the best way. Abdominal muscle contraction is the other one, but for that we need to examine the abdomen to look for abdominal muscle contraction. But by far we look at the neck and go by work of breathing that is increased.
So there's also a question on whether NIV or high flow nasal cannula is better for oxygen delivery.
So, as I told you, there is one RCT which has compared the two and then said that there is no difference between the two. Our experience has been with the NIV. The initial part of the pandemic, the critical care team used a lot of HFNC as well. But in the current scenario, if you put the two together, HFNC uses a lot of oxygen, and hence NIV will probably be a better strategy at this point in time than HFNC. HFNC only gives a small amount of PEEP, a kind of 6 PEEP, which is generated because of the flow. So again, for patients who may benefit from more pressures, the HFNC may not be helpful. So I would go for NIV more than HFNC.
Thank you. So there's also a question from a mission hospital on what safety protocols need to be followed in a hospital that's planning to set up NIV in a mission hospital.
So NIV is thought to be aerosol generating procedure or intervention. So, and we know that aerosolization increases spread of COVID to healthcare workers. That is why we put several check mechanisms in place as well. But anyone who's managing patients who are on NIV need to be on full PPE, including a N95 mask, visor, and full cover for best protection from transmission of the virus to the healthcare workers.
Thank you, sir. Ma'am, there's a question on whether myocarditis was commonly seen in ICU patients who were sick.
Yeah, so I've just written in the chat box that we hardly seen myocarditis in our group of patients. Actually speaking, echoes or cardiac enzymes have very rarely been elevated. Yeah.
There's also a question on whether rising lactate levels despite adequate oxygenation and normal blood pressure indicates an increasing work of breathing.
What I can say based on, again, on experience, surprisingly, despite seeing increased work of breathing, the lactates have very rarely gone up, very rarely, except in the patients who have had shock. I guess I'm just wondering whether it's because most of our patients are much younger than the population in the West. Our population is about 10 to 20 years younger than the population in the West. But despite having a respiratory rate of 35, so that can't be used as an indicator for increased work of breathing. It's more clinical examination, as Dr. JP has also mentioned, respiratory paradox. All those are useful tools to look at and assess at the bedside.
There's another question on whether the shunting of blood is due to thrombosis.
So when I say shunting of blood, just want to take you back to the cardiac thing. So you have left to right shunting of blood across defects. So here again, you have shunting of blood across an alveolus, which is not well ventilated. That's what we call about shunting. Now, thrombosis, yes, can result in shunting of blood across different other capillaries, various other capillaries. There can be shunting of blood. But if you have a very major thrombus, it can actually result in more dead space. That means the space does not get perfused as much. But if it's that's only if it's a major thrombus. We have small clots sitting here and there, that can also result in shunting of blood.
I hope this session has been useful to you. And if you need a recorded version of this talk, you can email a CCC. They'll be able to share the recorded version with you, and you can show it to your colleagues or your friends. Thank you very much.
So I'd like to thank today's resource persons. We had a moderator, Dr. Balamugesh, who did an excellent moderation, and the speakers for the excellent talks. And also the queries which have been posted on the chat box, and we saw Director J.V. Peter also contributing and responding to various queries in the chat box. And we hope this session was useful. And as we posted there, this whole lecture series, once it's recorded, is available on our YouTube channel for COVID-19. And next weekend, what we're planning is, as you have heard that experiences from within CMC, next weekend we're planning a session of COVID-19, an experience of second wave from our mission network. And we have 3 or 4 mission hospitals who will share their experiences from rural India. So keep tuned in for further information, which will be shared with all of you. So thank you very much for participating, and have a safe weekend. God bless.